I think we have a good morning planned. I don't know if all of you were like me, but I went home last night, and about the time I was trying to go to sleep, my mind just started turning questions and thinking about this and thinking about that. So I didn't get a lot of sleep, so thank you all very much. It was great. There's so much to think about, so many different aspects and angles and thoughts. And that was the purpose of yesterday and today, to really try to help us, if we move forward in this direction, in this state, that we do it well aware of where we're going, as opposed to kind of backing into something and looking down the road and saying, whoops. So I think that as we have our discussions this morning and presentation this morning, I hope that we continue to kind of get our minds filled. To introduce our speaker, I want to ask our co-host, Sue Elliott with the Arc of Washington State, to introduce Barbara.
Good morning. And like Ed, I couldn't sleep last night, so thank you all. And it's with great pleasure that I introduce Barbara Brent. I've known Barbara for over 20 years, I believe. Barbara started off in Oregon working for the Supported Employment Initiative and moved on to the state of Tennessee to be their state DD director, and then moved on to the state of Arizona to be the, I think, did she follow you? Yeah, to follow.
Follow him everywhere.
Yeah, right, you follow him everywhere, right. And now she works for the National Association of State DD Directors. So it's a great pleasure to welcome Barbara, and you can share with us all of your knowledge in like 30 minutes, right?
I think I have an hour, right?
Okay. Yeah.
All right. Good morning. And I didn't sleep last night either. My plane was canceled, and I arrived about midnight, but all is well. And, you know, Rick, who knows me the best, knows that that just creates more hyperactivity. So he can help say, calma, calma with me, so I don't speak faster and faster. First thing, the first disclosure is that I have way more material than will fit in an hour. That is by design, because what I wanted to make sure that you have, and you'll get the PowerPoint, it's not yet uploaded onto the server, is that you will have some tools that you can use later. And the tools are things like checklists to remember, of areas that you'll want to go back to as advocates, as self-advocates, as family members, as policy people, things to go back to as you think about, if you're going to do this, what are some of those areas you would like to talk to others about, no matter what your role is. And I have a timekeeper because it is more material, and Dave is waving, and so you'll do the 15 minutes, 5 minutes, and this. Okay, oh good, and they're big letters. That's even better. And you said tap it 20 times until I hit it? Okay, that worked. So what I hope to cover with you today will be a little bit different, and I'm so sorry I wasn't able to join you yesterday. I had some family obligations, but I hear the presentations were great, and I know my colleagues that presented. I do want to find out later whether Rick said a lot of the same things that I would have about Arizona, hopefully. And is everybody able to hear well? Great. And I'm not talking 90 miles a minute yet. So.
Oh, now you know. You pushed them.
Oh, see? See, I did it all by myself. Okay. So, and we all know these things, but I just have to remind others about why there's a sheer naked panic around systems change that the whole country's feeling. And these are not DD statistics. They're not necessarily statistics associated with those of us that are working in home and community-based services. It's reality, and it's coming from, oh yes, I started getting the AARP magazine without my permission or request. And then I feel badly because I find some of the articles good. So these are recent, within the last year. even though I'm upset about reading them. But I like to see those actors that are now turning my age and they look vibrant. So, we all want to be some of the gray people, but look at the number of Americans who are going to need some long-term services and support. We have to confront our realities. And then also look at the number of Americans that it's going to double to the number of people that are going to need long-term support by 2050, which seems to be clicking along. And so it's not just us, it's our own family members. And whether it's by age, whether it's by disability, we are hitting something that, hindsight is 2020. As we were here on the planet thinking about the world, getting excited, buying our first cars, thinking we're going to own a home, we're going to have kids, they're going to go to college. The policy, the term, of course, is thought leaders at this time. We weren't thinking. Now take a look at the shortage of caregivers. We know most of the workforce that is providing direct support professional work, no matter where, whether it's supporting people that are elders or supporting anyone. If you look at one line, the females ages 25 to 44, who are our home health aides, or supporting people with disabilities or people with physical disabilities or IDD. You got one trend line showing it's not growing, but look at what's happening to people who are becoming seniors, who, by the way, are also the group that is growing and growing according to our national core indicators that are supporting loved ones at home that have developmental disabilities. So I'll get less depressing soon. Look at the caregiver ratio plummeting. And there was a time when we had a lot more people that could support us. And remember, this age range is supporting people with disabilities in their own home. And it's not looking terrific. So we have to do something, right? And even the Wall Street Journal's talking about it for both people who are elderly and those with disabilities. And it's worsening. And we know wages are important, but we also know that we have a limited tool of people. So we've got to do something about it. And then, we do hear politicians talking about what's going on with funding. And it won't be long between Medicare and Medicaid making up more than between 20 and 25% of every dollar spent in the federal government. And that other, by the way, includes everything from education, defense. It's a little bit frightening. And then let's think about it's a small chart, but you're getting it, in the context of what's going on and, where people are living. And sure, we all know this because we're in the field, that people aren't in the larger group homes. They're no longer in the institutions. And if you look at particular states, here are the higher states of people living in the family home or on their own. And then here are the bottom states. And not that there's a huge gap, but Washington does have a number of people living in residential. And so just a question, why would this state be on the lower end and have fewer people living in the family home, receiving services?
Because their waiting list is so large? So they're not receiving services?
No, these are people receiving services enrolled in the system.
Well, I don't know, it's a little contrary to what we think we know, which is about 82% of the people who receive services receive it in a community living situation, and many of those are in their family homes.
Okay, so these are the data that come from the state. So, so there could be something about how the data are being reported.
Does this include aging though?
No, this is DD.
Wow.
Yeah, I don't think that's right.
Okay, so it might be something you want to look at, but it may also be in part due to waiting lists, so that when people come off the waiting list, they're going into residential. So just check your numbers. But the point is, more and more people are receiving supports in their family home. And so what are states doing? You've got an economic crisis. You've got issues with more and more people are staying in their family home. We've got a shortage of caregivers, and states are taking different approaches to deal with it. So you've got everything on focusing on employment. Washington's a stellar example of this. They're looking at supporting families, and that isn't just respite. It's a whole lifespan of supporting families. They're looking at rebalancing. So, less focus on larger residential, less focus on group homes in and of themselves, and looking at other models. Creating support waivers so that there's a series of waivers that can provide everything but residential. They're looking at resource allocation to try to figure out what are the best supports that can be provided within a certain amount of dollars. Looking at new federal authorities, it was mentioned in here, hey, let's do a K, an I, a J. And the reason that they have different alphabets is that it's when they were developed. So first there was a, then there was a B, then there was a C. There's really no other magic answer. And finally looking at managed care. So the whole idea is to nudge the system, to move from, and you know this, from the ICFs to the community ICFs, and what are those little steps that can be taken along the way that moves the system toward good values, our continuing values, and they also happen to be cost effective. So why managed care? You got a lot of this yesterday, so I'm not going to spend a lot of time there. But it can allow a state to more predictably look at their costs and limit the financial risk. And it can create more flexibility and serve more people if it's done really carefully. So it can. It doesn't always. So where is it? Where is managed care? Most of you know this, but just in case, and remember, part of what I'm giving you is information you can use elsewhere. That's why you'll get the PowerPoint. So 1 in 5 Americans are enrolled in managed care. How many of you are in some sort of managed care plan? And 65% of all Medicaid participants are in managed care. That's mainly in acute. There are very few states that don't have some kind of managed care, but it's mainly, again, in acute care for if you're in Medicaid. It's much more common, and you know this already, for people that are seniors or have mental health support needs to be in managed care. It starts dropping rapidly in developmental disabilities for a number of reasons. So you wanted a little picture? Here's your little picture, and you've heard from some of the states today. So you've got Arizona, which you heard about. You've got Michigan, which you've heard about, and these are different waiver authorities. Wisconsin. Texas is moving into a pilot for developmental disabilities. They're heavily invested in all their other service populations. And this was not without controversy by the ARC there and others. North Carolina is in a BC. It's not been without problems. There is a legislative mandate to analyze going into 1115, not without a lot of problems. New York started off going into an 1115, and now they're being asked to do a BC, and it's going to be a slow rollout. Kansas is in an 1115. They're in pilot now for people with IDD, and I was just there last week and can tell you a little bit about that. California has exempted most anybody served through a regional center, and regional centers there are not developmental centers. That's their regional county system. Kentucky's in discussion. Georgia's in discussion. Louisiana has just sent out their request for information that will include IDD with an RFP to come out soon. New Jersey has one. They're rolling out in another phase for IDD. Florida has legislation that's dropped again. Ironically, the providers are the ones interested in the DD providers, as long as they're the MCOs. Hawaii is in discussion. Illinois will include DD in phase 3. This changes constantly. Okay, so you know this, right? But when you talk to MCOs, or you talk to legislators, or you talk to people in the state agencies, or you talk to people that are supporting seniors or behavioral health, sometimes they say, why are you being recalcitrant? Stuff you know, right? But these are some of your talking points about that people maybe don't know. You know it. And I think it's important to be able to point it out. Who built the system? Families. You know it. And then the whole issue around who made the statutes happen. Who created the impetus between all the congressional components? Who made sure that there was Medicaid services in the first place? It's been a long, arduous, important road, and it's been going on for decades. And some of the other populations may not know that. And certainly for an MCO, particularly the private MCOs, because what you've heard about primarily here from your managed care experts, these are publicly run and publicly overseen MCOs, except for a few of the Wisconsin areas, and it makes a difference. So people need to hear why the difference. You know it, but you need to be able to explain it to others. And so when people say, well, what, I just came back from Kansas, and they said, why are these families so skeptical that are in 1915C waivers now? So they're used to having a state DD director as a high-level executive branch agency, and they know who to call. And everybody at this table that is in an MCO area, they know to call you. They know to call Rick, and there are many families, they knew to call me saying, how come you did that? This is your fault, fix it. And if you end up going a private MCO route, there's a call center. If you have a complaint, press option 1. If you have a complaint, press option 1 again. So there is a difference that people need to understand. Families and people with disabilities have been valued stakeholders, and in the classic MCO, and this is changing, they need to really understand, and you need to make this point, they are not used to having self-advocates and families and other advocates expect the meeting once a week or once every 2 weeks, or they're used to more of the suits coming in around capitation discussions and rates. Also, service, the single point of entry, you guys are used to knowing, you may not like what the answer that you get, but used to knowing where to go, right? You've known the county, you've known the agency, you've known the state. There are relationships. I'll get into service coordination in a minute. There's been more of a lifespan. You've probably known people from early intervention on over the years. And the provider network is one that you know, right? It's been your touchstone around, a lot of them have been nonprofits, a lot of them were mom and pops that grew up. And when somebody says, well, there'll be better oversight, whether you like the oversight or not, it's been there. The licensing, the certification. So there's a sense of the familiar. So when somebody comes in to say, managed care is going to fix everything because look what we're going to offer, there's that little voice that says, what about us, right? So, again, these are things you know, but you need to be able to bring forward. I'm not going to talk about it, but we already know that the DD system has decades of a system of relationships that a private MCO is not likely to have. They have not known you for 30, 40 years. Hey, and people love it, say, hey, you're going to control costs. That's really attractive to hear, right? Because it's not an entitlement now in your 1915 Cs. There's already limited appropriations. Enrollment's capped for most waivers, how many slots there's going to be. And that when you think about traditional MCOs, at least in the past, and I'm not talking about the states that spoke yesterday, but this is not the group that is high users of hospital and healthcare services, despite what you may hear. And the data prove that. And people are worried about that waiting list. The system's already rebalanced. There are very few states that have a high number of institutional use or nursing home use around DD. And when people hear saving money, it always means that's cuts. It's not the same kind of thing you might hear in, it's not attractive when people hear it, right? So you know the answers. What's important for people with disabilities and families to hear? I'm not going to read them to you. What are they? If you're going to go to a managed care, what do families need to hear? And you're really perky this morning, come on.
The thing that people always say, I'm a parent advocate, is that they want a break once in a while, they want very good information, and they want their son or daughter to do something decent when they leave school, which is, in our state, we are focused on jobs for the most.
Okay.
Those are the things, those are low-cost, high-impact things, and those are the things people say year after year after decade. Is that what you asked?
Yes, you did. Yes, you answered. So if you're going, when somebody says, let's do managed care, you said transition from school to adult life, a job. People want access to services. What else?
You want a system that really works, that they can have access to, that is functional, and doesn't limit what they need to have done for their sons or daughters.
Good. Well, flexible, that works, meets their needs. Yes,
Well, and there's more and more talk about self-directed services in our state, too.
and self-direction. So, do you think those are the typical conversation, present company, states included, that a managed care organization might be used to hearing? So you might have to guide that conversation, right? So you've already named them. What do families need to hear when talking managed care? You already did it. They're all there that you talked about.
And the wait list.
So it's there. And then I'm not going to belabor the point, but and again, because time's time, is that you're also run the chance of hearing within the MCOs within your Medicaid agency. Sometimes some Medicaid agencies aren't like this at all, but from a legislative standpoint, I get choked up about it. Federally we certainly do, is why are the DD agencies the special snowflakes? So we hear it a lot like, well, why are you the most special snowflakes? Why do you have to be so different? And it's because in thinking around managed care, it's not the same, right? And so you need to think about how you would approach in a positive way and without being defensive to show why managed care services and supports, or any services and supports, managed care or not, that the population support needs are different. And I'm not going to read them all, but to highlight a few, the focus for seniors are supporting people to have the best life they can in their remaining years of life. And we know, but others may not without you pointing it out, so these are some tools for you, is that for people with IDD, it's getting a life. So they have to think about their costs and their planning processes for 20, 30, 40 years in learning and growing, right? So when they think about their fiscal models, their service coordination models, it doesn't look the same, either in their cost modeling or that points of engagement. And we talked about the length of service. Their cost savings are often keeping people at home and avoiding nursing home care. And cost savings are a little bit different. And you rebalance the system, of course, but you're still there for the long haul. So you have to think differently about what the cost savings would be. And the MCO financial savings, it really is to avoid nursing home costs and providing good supports in the family home. And then in DD, it's smaller is better, right, in terms of financial savings and getting people jobs. That's been talked about here. And then a couple other things around care and supports. For seniors, medical supports are primary in helping people stay at home and have, for IDD, the medical support needs are there, certainly. If you're not healthy, it's hard to have a good life. But how much time for those of you that are people with disabilities or family members or advocates, how much time do you talk about primary health care? MCOs are not used to that, or those that are administrators around supporting seniors, not used to it. And family caregiving, how do you support family members for those beloved last years of a senior's life? Whereas family caregiving, it begins at birth and lasts through a lifetime, so it's lifespan supports. And even for those that support those with psychiatric support needs, sure, family caregiving is intense, yet it is more episodic rather than every single day, except for some families, of course. And so you've got to build natural supports that are over a lifetime rather than maintaining the support somebody who is a senior has had. So that's a different model in terms of planning. It's a different model in terms of financing. And it sure is different when people start getting calls in those MCO agencies saying, I want, I need. And for the fiscal folks in your state trying to cost model this, oi. As I was just with Mom. And she said a lot more than that. Words I did not know she knew in English. So very quickly, and you have a lot of this on your resource materials, the CMS put together their expectations of managed care programs. Planning and transition, we could spend a year and a half on, or a week and a half on, and that will be your key to the kingdom here. And I can't emphasize enough what planning and transition would be if you decide to go into managed care. This will be anything from health and safety to success. Stakeholder engagement, making sure you stay in the most integrated setting, alignment of your payment structures, support for what they call beneficiaries, you know your people, person-centered processes, integrated packages, qualified providers, participant protections, and quality. Let's roll. And then the managed care principles that were written by our association on behalf of the National Council of Disabilities. I think that they've already been loaded, right? How many minutes do I have? 30? Oh, I'm good. I'll just talk faster and faster. Okay, so I won't go through them. So those principles outline each of those areas, which are also on your tool sheet. Again, I could spend hours, and I have 30 minutes, but all I will say about readiness and phase-in, when states have implemented managed care for IDD, this is where there's been a bit of a downfall because it's complicated. It involves huge stakeholder involvement. You can't lose your provider network, your mom and pops and your small providers. Providers have to get paid, and the management information systems. I can't speak for Rick. I can speak for me. I was astonished at the amount of data that was needed to run a managed care system. And understanding the data was the next thing. And then keep what's working. Don't lose your decades of good values-based systems for the sake of managed care, and that takes some readiness. What's your outcomes, your safeguards, and more. And I'm not going to read all these, but you need to keep your provider networks. You need state staff that are excellent in keeping the DD focus. And your backup planning, so you don't lose the providers that you know in the process. And great transition planning so that nobody gets lost in the shuffle. No matter how many letters you send out, somebody moved. With our recession, people have moved in with other loved ones. You may not know where they are. People have lost landlines. They use cell phones. Finding everybody. And so stakeholder engagement, there's the Medicaid necessary engagement, right, where they have to put out public comment. There is sometimes it's the providers that have the most information and talk to the people receiving supports and services. They're probably a vital touchstone. They should not be your primary touchstone because that's a lot for them to have, and it doesn't build the same trust. Nor would you if you go to a private MCO. It doesn't have the same weight as having the state be known as, we are still your oversight entity. We care, we're not going away, and we're going to make a difference. And just a point on how you would try to do managed care if you go this route is that the states that you spoke with, the state is involved. There's some government involvement. So in Arizona, the state is the MCO, the DD agency is the MCO. It has the direct contract with all the home and community-based service providers. It subcapitates to its plans for acute care services, health services. Behavioral health has a little hitch in our giddy up, but and in Michigan, there is a more direct government relationship. In Wisconsin, there's some. There was more at one point. There's a little less. In Kansas, there's none. It is directly to private MCOs. Now, think about this. If it goes completely to private MCOs from your Medicaid agency, if there is not something in the contract that binds them to your DD authority, rules, policies, practices, everything you've built for 40 years, how are you going to make sure that your positive behavior supports, your focus on employment, your rights and responsibilities, everything about, my goodness, the right to be able to live with others, date of all things, everything you've put in there around service coordination, how are you going to get a private MCO to do that unless there is great intention to make sure that happens? Because what else is going to bind them if they are not run by the state? So anyway, get those stakeholders in there. And then make sure that those stakeholders are,
Is this on your website? 'Cause I don't see it on the website. Are you loading this onto your the NASDDDS, whatever?
This is not, this is a presentation that we put together, but this will be available for,
On where?
we're giving it to you, and
It's gonna be on the council's website under forum.
Council, okay.
Right, it's the same place where you go and you look at the agenda, and there's a link to Barbara's
Perfect.
presentation.
Uh-huh.
But as Barbara explained, she's late getting in. We haven't got this posted yet. So.
Stakeholder engagement is a little bit more. For those of you in managed care world, there's these external quality reviews. If you read them, it's pretty exciting. You want other kinds of things available to you that are meaningful, that are population specific, and they talk about you want other things available to you as stakeholders and as state government. I don't know where you're from, if you're legislative staff, if you're, you'll want things that are really meaningful around quality of life for everyone. And yes, you can get them by MCO. There's a concern that's only an aggregate. No, you can really get them by any way you'd like, and people really like them. And so the place at the table is not just in developing, doing like you do now. Make sure there's a way for, if the state is not going to be the MCO or not going to be the guiding entity, make sure it's in contracts that there's going to be regular stakeholder engagement with the MCOs. It can happen. What should be in the MCO contracts? Most of these states have done a very good job in having some prelude that's in the contract about people can live in the community, and irrespective of their support needs, and have your list. And use words that may not be typical for MCOs. Particularly, again, I'm speaking to MCOs if you end up in private MCOs rather than the government not being the MCO. They're not used to the words like behavioral reputations, or they're not used to people on G-tubes and trachs or living in the family home or, in other kinds of settings. Lay it out. It's an idea. I know I don't have a whole lot of time, so alignment payment structures with goals. There are some places that have removed the capitation. So remember, capitation is not resource allocation. Capitation is the per member per month. And some have carved out the nursing homes and the ICFs and have held that kind of harmless. It's outside the capitation. It's pretty hard to rebalance your system if not all the costs are in there. Whether there's an intent to close ICFs, that's a policy decision, it's a political decision, but if you don't know where your costs are and they're not included, then it's hard to really watch them. And then so you find a way to invest some savings in the waiting list. A lot of times you do that through rebalancing. States that have not thought about investing something in their system, right? If it's all, this is all we're going to get, this is your pie, and you're not going to even add a piece to the pie, are going to have a harder time addressing their waiting list. And states that have not said, we're going to rebalance by doing some other kinds of things for smaller homes, diversion from nursing homes, diversion from some of the larger settings, are going to have a harder time getting to their wait list. And then capitation, remember, that's the per person per month. It's not everybody, it's like those of you in managed care now, if if somebody's paying $1,000 per member per month for my health care, and somebody else better only be getting $200 worth of services, or there's no savings. But capitation's not a personal budget. It's not you don't do a CIS score and get your money. So ideally, capitation's not just what you spent last year, which is what some states have done, and it hasn't worked very well. So it looks at the future. It's not just what's going on in the industry, how much you spent last year. You want to push for, what do you want to become? So if you want to do more around supporting families, even if it's some blessed respite, even if it's to build more in-home supports, get your demographics, get your data about who needs what, how many people are aging caregivers, how many people are exiting school, and build that into your capitation. So you need good data. So it doesn't have to just be, we spent that much this year, we're going to have 20 more people entering by this many counties, and there's your capitation. And that's sometimes hard for systems and Medicaid systems to do without a little bit of education because of the population differences. Rate setting, always a little dicey. What will you pay your providers? Which again is not capitation, but how do you set your rates for what you want to have occur? You guys got employment down, at least as we understand it. But then what creates a full life? Because we know that employment is a part of the day, but what creates the other support for a full day? And okay, so here's my pitch to you, is that network plan, network sufficiency, network plan. And if I haven't mentioned it before, network plan. Most MCOs, particularly if you go private, will say, and Medicaid plans will say, you've got to have enough providers to adequately meet the part of your network, right? So that in classic terms, that means there's enough developmental pediatricians, we have 20 group homes in this area, we have 14 respite providers. But if you want to move the system in the way that you want, the network sufficiency plan is going to take a careful look at everybody in the area, by county, by zip code, and what it is based on people's plans they want and need. So if they need more support for family caregiving, more people want to work, more people want shared living or other kinds of out-of-home placement, you build it in your network plan. You don't delegate it. Not only do the MCOs have to have one, it's measured. The state oversees it and gets quarterly reports on it, and it's part of what is measured. Otherwise, it will only be seen as sufficiency rather than a tool for improvement. Okay. You already know what support coordination is. This is what in DD we do. We already know support coordinators don't work for a provider. I'm good. And they develop a relationship. You may not keep the same support coordinator, but you kind of know the entity, you kind of know what to expect. They're there for ad hoc problem solving, and maybe they can't give you everything, but you know who they are, because you're in the system a long time. So if the state, again, if your state is not the MCO, how will the state make this happen? So care coordination, if you're in an MCO now for your acute health care, I have epilepsy. My care coordination is they send me a postcard saying, did you take your epilepsy medication? Well, that's helpful. And sometimes they call saying, would you like a special care coordinator? And for kicks one time I said, hey, sure. The nurse called me and said, what are your medications? I said, well, I think you probably have those, but I'll read your sheet and so let's see if it matches mine. Well, it did. And then they said, did you know that you should get a lot of rest? You bet. And then did they say, did you know having a healthy diet? Yeah. So in care coordination, in a typical acute care MCO, is not going to be the same. And the average MCO that is not a state run MCO, they're not used to it. They may be used to an assessment tool. this universal assessment tool, but they may not believe in the whole picture. And just a second here on medical necessity versus having a good life. And I think in Arizona, we were pretty successful in meeting the medical necessity threshold to move it from medical necessity, which we had to have for acute care, to what's the context of a good life? What was necessary to have a good life in the community? So, sure, you could have, what's necessary? Oh, you could use the term all you want, but for this young girl, to stay at home, yeah, she ate through a tube, but she has 4 other siblings. Her mom works. She has an extended family that likes to provide a lot of support. Very loving. She lives in an urban area, so transportation's not been a big deal, but she does need some medical support, but mostly she needs to be able to romp with her siblings and be with them and go places. So her life was not mainly around medical, but the social support that was needed in the context of her family and her day was mainly other HCBS services to be in community. The medical necessity was mainly around that tube care. So building the rhythm of her day through not a fancy universal functional needs assessment, we were able to show what was necessary to have a good life. And there's some tools to do that, and we don't have time to go through them today, but you have to help people get over the medical necessity threshold. Okay, don't want to make too many people mad, but you're going to hear about ADRCs and options counseling, and there's a way to make it work, and as it's currently lined out, it's only lovely in a few places. So as it's particularly lined out, and I can't speak for it here, I don't know it. Options counseling and assessment, if the need is X, there's usually a process to say, wow, have you thought about Y on the menu? And the assessment leads to knowing at least an outline of what is needed. And that there's a list of services that can help lead to service assignment, right? So, and when we do bad support coordination in any system, right, it's the same thing. Here's your menu of services, and by the way, this is our special, but we're out of it today. And that can be a danger with any new program, like an ADRC. And what we're used to is a conversation. It's not just the support needs of the person, it's their whole family and social context. And the person defines more what is needed, and then you try to figure out what might be available based on who they are. And both the ADRC and person-centered work here tries to figure out the community resources too. But there's some work to do in the ADRCs. Okay, so if the state is not the MCO, and you go and say, let's do our planning, and you say, guess what? John wants to be a fireman. Alrighty then. What's the average MCO going to do? So there needs to be some coaching around their training as MCOs and their service coordinators, support coordinators, and others around, well, you get all this, right? You get to why somebody wants to be a fireman and status, respect, excitement, and then, but there is a role for them. Maybe that person's overweight and has diabetes, and then what are those solutions around joining Weight Watchers, starting a dog walking business, but this is not typical without intentionality in an MCO. I'm not going to go over this. You know what comprehensive means in the life of people with disabilities. There are some opportunities in managed care, and we've all experienced them around staying in the home and community. If somebody has crisis issues, we know that you can, if you actually control the acute care and the psychiatric support needs, you can do a better job perhaps around polypharmacy, those things that avoid crisis, those things to have a rich and meaningful day, if you control all three parts of that. And then your support coordinators need to understand a little bit more about acute care and avoiding illness and how you can work those things together. I don't think we need to talk about employment much here, except somebody asked the question about how do you keep employment front and center in managed care. There isn't just policy and contract, but there's these things called clinical guidelines. How annoying, right? But there's some states that have clinical guidelines, very well written, that MCOs are used to. Have them for employment. Put them in your network plan. It's just not how many docs. Supporting family caregivers, put it in the contract. You don't see it in too many MCO contracts. I'm going to highlight 2 points on qualified providers. Your providers, if they're not your traditional providers in DD, need training in IDD. You got to keep your small providers. That's where your innovation is. And then your provider agencies, not traditionally trained in managed care, need a bill whisperer and a coding whisperer because they are not used to this and all their claims will bounce. So they need that support, even if it's a little bit annoying to MCOs that are used to it. And your MCO staff and enrolled providers not only need training on what really is person-centered practice, they need training on self-determination and IDD and have people with disabilities and families as trainers. Okay, quickly. MCOs, if you've gotten your right and member handbook, right? About you have the right to appeal, anything you say will and be held against you. No, they actually do try to help you with the basics. Tell me, how many MCOs are used to having this in their rights and protections? This is not typical. So those are things to help build it in there. All this is to say is that the state's role cannot be underestimated, and that it has to be built in, particularly when there is, if you're going to go private MCO. Get your employment, family support, school to work transition built in the contract. Not all MCOs have real-time quality management and incident management, evaluation of support coordination, which is going to look different, and that the MCO quality is huge, but the state's oversight of the MCO is even bigger. I've already talked to you about network capacity, and that says something really tiny.
Questions? Time for questions? No, I just wanted to key you to leave some time for questions.
Yeah, it says that I need glasses. So there are ways through the network plan, you're not going to have a 300-page contract, right? So have policies, manuals, guiding, and guidelines binding in contract. And so I've got a whole list of tools where you can get involved to make a difference that you can reference later. Innovation, where art thou? How do you build innovation in managed care? Think of all your thought leaders in DD and how to build that into MCOs, because it's a very organic process in our history, and how you'd have to build intention in managed care and continuous innovation. So it's more than a financing mechanism. You got to define your quality outcomes. You seek opportunities for integrating care, self-direction, support more people and their families in the community. That's progress. And thank you.
We have a little time for questions.
Questions?
listening to the presentations from yesterday and you today, why wouldn't we want to have a more state-administered MCO? It seems like we have more control about the values and making sure that certain things that we wanted to continue. Why wouldn't more states do what Arizona did?
3 reasons. One is, would CMS allow another state entity to manage risk, even though we all know states manage risk all the time. So it's having that conversation. 2, it's state politics as to whether private is better. And 3, state politics as to whether private is better.
And for the risk. Yeah.
Well, and the risk really is still on the state, but it's whether CMS, from a classic perspective on managed care. And there were a couple other hands up. Yes.
That was essentially a big part of my question, but your last statement kind of gets to another kind of slice of that, and that is, if you do have a private MCO, who is the federal government dealing with in terms of providing the funding? Is that going directly to the MCOs, or how is that working?
It's still the Medicaid agency. The legislature puts up the match. Medicaid's still the single state agency. The question that is in those states that are going to private MCO is the level of engagement and authority that is given to the state Health and Human Service, the DD authority. How much delegation and oversight will be given to that agency to make sure the policies, how much can be done together, how much can the policies be written and be put as binding in either contract or manual by the Medicaid agency.
So in a state like Kansas, what kind of responses are the advocates giving with regard to kind of having a great deal of control in the private MCOs or a great deal of delegation?
It's rocky. And so because one got out ahead of the other, it went very well for people that are aging and fairly well for behavioral health, not so well for DD because of some of the readiness assessment. So now they're retooling to see what they can put into policies and guidelines and practice to engage the stakeholders. Yes.
Okay, this is going to seem like a very simple question, but I don't understand how we can take an already unfunded or underfunded system that cannot serve everyone currently, mix it with a managed care system who honestly is struggling to do health care. Forget anything else, they're struggling to do health care. Give it to a private entity that's going to make money on it and us still serve everyone. That math doesn't work in my house. So I just, you know, I mean, I see the charts, I see where we're going, I know that we need to do something different, but I'm not understanding how all of those numbers are actually going to work and it not just result in lower services for everyone.
Mm-hmm. And I can't answer those questions without a lot more detail from your state and what the intentions are and which waiver authority would be used, whether there's any intent by the state to infuse some more money into the system. By the way, not all managed care systems serve everybody. Kansas has an 1115 that begins to add more and more people from the wait list as dollars become available. North Carolina's BC combo does not serve everybody. And Wisconsin's does not serve everybody.
Can I just add a comment about Wisconsin? Technically, Wisconsin, what the state was predicting is that the rate of increased spending would be lower than if they didn't do managed care. So they technically were not saying,
Correct.
when the baby boomers need long-term care, we don't expect to spend any more money. What they were saying is, without managed care, we project a very steep increase. With managed care, we think it'll be less steep. And part of their reasoning was, nursing homes on average cost more than living in the community. And if we don't do this, we don't eliminate waiting lists, we think our nursing home utilization is going to be much higher.
And if I can add to that, for Michigan, we have seen a much lower, slower rate of growth every year than we would if we were looking at fee-for-service. And so our growth rate has been in the 2 to 3%, maybe 5% some years, which is much less than it would have been in the fee-for-service. So you have to look at more than just, what you're at right now. And we're looking at 15 years worth of that pattern. So over a course of years, we've saved a tremendous amount of money, and clearly in Michigan are serving everybody, as best we can.
So based on that, one thing I think is important for you guys to realize is, if people in Washington are talking about, managed care will enable us to have a net reduction in spending on long-term care over the next 10 years, I think you guys should say, no, that's not what's happening in the other states.
That's right.
Because if people buy into that view, and then you try to end waiting lists, and you try to deal with increased demand because of the demographics, and have a net reduction in cost, you will probably be seeing some pretty draconian actions in terms of individual service plans. So you should try to stifle any talk about, we're going to free up $30 or $40 million that we can spend on highways. That's not going to happen.
Yeah, and it's sustainability. It's bending the cost curve. Excellent point.
Can you talk a little bit about New York and where they're at in their planning and how they're proposing to approach that?
New York, I started to go down the road of 1115, which would have been greater entitlement, and New York's big, right? They were going to infuse a lot of money, and it would bend the cost curve. A lot of things happened in New York where they did not have one door, and there were separate waiting lists depending on which part of the state you were in. So it wasn't easy to find out where you were on the waiting list. There was also a lot of provider control as to who got in, who got out. And so they are going through massive change. The 1115 was not considered at that time because there was a belief there'd be more control and oversight through the BC waiver. At the same time, they're in a massive agreement with CMS. They have closed the door to all their sheltered workshops. And for them, it's really big. It's not like they have to close the door for 7,000 new people to come in. It's more than the West Coast population. I'm exaggerating, but not that much. And they're in negotiations around moving people out of larger private ICFs and things that we don't have in this part of the country. So it's going to take a long time. Their BC is not even in for approval yet because of the other negotiations.
Just talked to the gal the other day who's still trying to write it.
Yeah.
Are they thinking private or state administered?
Both. They're looking at going to DISCOs, which are regional authorities. That's the name of it. And originally it was going to have private DISCOs, but because of the quasi-governmental component, they were going to use like a lot of the ARCs that are also service providers. They're the big service providers there. But it's looking that the financial risk corridor that they need is in the hundreds of millions that they're not going to be able to carry, so it could likely be private MCOs.
Would you be so kind to tell me what BNC is? I've been going on the fact that it was maybe 1115 BNC. I mean, I don't know. I just don't know.
I'm going to let RBC person explain that. They are 1115 is a demonstration, and Arizona has the longest one, and a BC blends what you have with a 1915C with some of the B flexible managed care services.
So were they called 1915s?
Camille, or?
We can tag team on this since we both have BCs. Remember what I said yesterday, that 1915B is just a section of the Social Security Act. And that's the section that allows a state to be able to create a managed care entity and use a capitated funding system. And one of the things that it does is, and Camille had mentioned this yesterday, was it waives your freedom of choice of provider at the level of which door do you go through to access your services. Not at the level of the choice of providers who are going to touch you on a day-to-day basis or work with you, but at that level of waiving freedom of choice of providers so that you have to come in through our managed care door to access those services. So that's the big authority, that's your overarching managed care system. And when we have a concurrent C waiver, it typically, in both of our cases, I think, was an older C waiver because 1915 C authorities were used long before B waiver authorities were being used. So we had some sort of an existing C waiver and we would tie bar them together. So in my case, in Michigan, that C waiver is also paid for using that same capitated system. And you want to add anything to that? And I want to just tell you, we're actually moving to a 1915I. There's new information for you. And eliminating a concurrent C, so we'll be a BI state.
The only thing I would add is that, and she's exactly right on all of that, it isn't, don't let all of the acronyms and names seem intimidating. They're really just that. And once you look at, go into the website and look at just the 6 assurances for a C waiver. And it will all come to pass that actually the values that we have built into our systems are those 6 assurances. And it will bring comfort to you instead of hearing us go I's and C's and J's and SPA's. We talk that way because we have to be technical all day long and talk to CMS all day. But I think once you dive inside and look at what the assurances are, you'll feel more familiar with what we're talking about.
It's fine. I get it now, but in any of the places I've been, they're not called B, instead they're called 1915B. I just didn't understand.
It's the same, 1915 BC.
It's because most of the DD systems are under 1915Cs, which are not managed care. And that's probably the common vernacular. And I've been told we can entertain one more question. Yes.
Our state is looking at the 1915K waiver, which allows training and stuff. So how would that work with the managed care?
The 1915K is a state plan amendment, and there would be it's a long conversation, and it's a new authority that is only recently, Oregon is your test case, and it's a long conversation, and it would be a complex change with opportunities and future wires. So, and it's probably not one that I can answer in a few minutes. Good match, good federal match, complex implementation.
Actually, one of the things I think it's from you. Didn't you make a chart, or NASDDDS made a NIFT
Yeah, we have
chart?
a chart of authorities.
So it's possible maybe that we could find a way to upload it.
Yeah, I can get it to you.
Some of the similar documents. It's a really nice chart that says this is what a B is, and what a C is, and what an I, and what a J, and a K is. And
But it doesn't have warning. I've got it.
Okay.
Yeah, okay.
Again, let's thank Barbara